Good evening, everyone. Here Imran Abbas. Again, we are live. I am live from Dubai and really great honor. Today, I am with Professor Shashank Shah, who is pioneer of bariatric surgery in Asia, in India, at the globe. No doubt, I am one of the follower of Professor since 2013 and really watching his videos, his work, and no doubt the role of professor, especially for promoting bariatric surgery, education of bariatric surgery, there is no doubt. And it's really great honor to interview such a prestigious figure. And my viewers, as you know, we have started this interview series since 2021 with MGB, OAGB for 6 months, and then safe sleep gastrectomy, that was also for 6 months, and then Roux-en-Y gastric bypass. And now we have started, and we are going to finish in December. It will be finished, this series, that is metabolic surgery in low BMI diabetic patients. We have started this series with Professor Alper Chilik, then Surendra Ogale, Antonio Torres, C.K. Huang, and many, many big names. And tonight, in my opinion, it will be one of the best sessions, because in my opinion, this series, that is the metabolic surgery in low BMI, still need to talk more about this. Sir, I will not take your time. Over to you, sir.
Good evening, everyone, and thank you, Imran, for this series. Very educative, and this wonderful topic, which is my passion, metabolic surgery for diabetes. As you know, I am Dr. Shashank Shah. I am a past president and trustee of Obesity Surgery Society of India. It's almost 20 years that I am practicing bariatric surgery, and the main focus was always doing research for metabolic surgery for diabetes. And I'm very happy to share the only surgical award given by American Diabetes Association so far is for one clinical trial from our unit, that is metabolic surgery for type 2 diabetes, a randomized controlled trial, which we will talk about during the discussion.
Sir, really great honor.
Thank you again.
Sir, great honor again. So it is also for my first time I hear about this. So you are someone who has achieved this also certificate from Americans, because this recognition is also very important. And sir, we have divided our questions in 3 parts. First part, that is also one of the most important, that will be patient selection. Our question will be about pre-op and patient selection. In second part, we will talk about technical points, that which type of surgery you prefer. And during that session, you can show us any type of video, any presentation. And third one will be your data, your results of your patients. So first question, already you have your brief introduction, already you done. And also first question, we are also interesting to know about journey of your bariatric surgery.
So actually it started way back in 2003, actually materialized in 2004. I must give credit to my proctors, Dr. Almino Cardos and Dr. Kelvin Higa, but more of mechanism, physiology was taught to me by Nicolas Copinaro, the founder of IPSO, the founder president of IPSO. When we went to learn bariatric surgery to him in University of Genoa, and we were all geared up to learn technique and trocar placement and surgery. And when we landed, he told us that first 5 days will be physiology of GI tract. Next 5 days will be altered physiology of GI tract after bariatric surgery. And the last 5 days we'll brainstorm on adaptation of intestines to this altered physiology over time. And those 2 weeks were probably the ones which changed my life. We started with gastric bypass and some of gastric bands initially in those times. So the career started with Roux-en-Y gastric bypass. Then we were lucky to have Michel Gagnère visit India, did some clinical trials, and we started sleeve gastrectomy, probably the first few ones in Asia. We've started it in 2005 and then evolved to different modifications, procedures as we see the journey of bariatric surgery. Is you can almost say about 10,000 procedures, but in today's time, procedures are evolving to practically 20% of revision or second or third stage procedures in addition to primary procedure. But the most important impact for Asians and Indians is on type 2 diabetes and preventing long term complications of type 2 diabetes, as you have chosen very correctly.
Sir, excellent. Definite and definite tonight, in my opinion, this will be definite a best session, especially for myself. Personally, I will learn a lot. Sir, so one question that is the most important, in my opinion, is patient selection. Because patient selection is most important, because especially when we talk about diabetes type 2 in low BMI, and this is our topic, how you select your patient, which patient is good candidate for metabolic surgery.
Very interesting question. And I must say, as the BMI starts going down, the confusion about true type 2 diabetes and some other types of diabetes can come in. And especially those who are latent autoimmune diabetes of adults, which is known as LADA, or some other genetic variants which may behave like type 2 diabetes but would not be type 2 diabetes. And that is why one has to be more careful as we start going towards a lower BMI. While we select an ideal type of patient for metabolic surgery, that patient will be anyone who has uncontrolled diabetes in spite of more than half the dose of normal medication, has attempted lifestyle changes, and in spite of all this, the disease is progressive, giving rise to some complications related to type 2 diabetes, and it is not treated by medical therapy alone. Those will be the ideal ones, but while we choose this at a lower BMI, one has to make sure that the fasting and postprandial or stimulated C-peptide is more than one to ensure there is no overlap of other types of diabetes. One has to ensure that insulin antibodies, GAD antibodies, anti-insulin antibodies are not present, which could be the reason to destroy those insulin in the body, and that is how the patient would get type 2 diabetes. The most important among all these would be patient who has central obesity, central adiposity, and a waist circumference of more than 100 or 110. So a patient could be thin, but a prominent belly would definitely fit more into true type 2 diabetes. And this is how we decide and choose a patient who is truly type 2 diabetic and then who deserves. Of course, if you look at the position statement of American Diabetes Association, IDF, all guidelines, any Asian above a BMI of 27.5 with uncontrolled diabetes who fails to respond to medical therapy can qualify for metabolic and bariatric surgery. However, we try to keep ourselves above a BMI of 30 and carefully select between 27.5 and 30 because there is a gray zone where there is a chance of overlap with other types of diabetes. So that patient has to be very carefully chosen with a discussion with endocrinologists. Another aspect. When I started my career and when I did clinical trials in today's era, I believe we have very strong newer anti-diabetic medication, which are very powerful, though the indications from 27.5 would move to a BM of 30, in my opinion. It may not be still in the guidelines because they are very strong. And this is how in present era, we have to balance between medical reversal of diabetes, surgical reversal of diabetes, and pharmacotherapy and choose an ideal patient who does not fit into this.
Sir, excellent, sir. Now we also are live, and Professor Lopez from Guatemala, he pay regards to you. because I can see here. Sir, you have mentioned, so one thing that is the most important, because you have mentioned, so when this diabetes is uncontrolled, how we define this? Yes, this is uncontrolled. So if we, it's necessary to wait till patient must start insulin, and now there is no response to oral medicine. How, what is the definition of uncontrolled diabetes?
Yes, so uncontrolled diabetes in medical literature has multiple definitions. But if you look at the diabetes organization definition, the average hemoglobin A1C should be more than 7.5. Patients should be on more than half maximum dose of different types of anti-diabetic medications. Only then the diabetes is called uncontrolled. Of course, there is addition of fasting, postprandial, other parameters of metabolic syndrome, and then we decide.
Sir, is period is also necessary? So you can see, so now 3 years, 1 year, 6 months, 5 year, then we can ask, yes, now the time we must go for surgery.
Very intelligent question. So, in those where the BMI is high, probably one may not wait for a longer duration of diabetes. As we know, at the diagnosis of diabetes, almost 70 to 80% pancreas is damaged, and complications start almost 15 years before the diagnosis of diabetes. This will hold true for those who qualify for definition of bariatric surgery and they have been diagnosed with diabetes. One may not wait and offer them surgical reversal of diabetes. But as we go to lower BMI, definitely whatever we may feel, we want to save the pancreas and offer early intervention to reverse their diabetes still. No one will be willing, no physician, endocrinologist will be willing. So there has to be a few years of attempt of medical lifestyle management. And if in spite of these, in spite of addition of newer medications, if the patient has a complication which needs surgical treatment or patient is not responding to these treatments or not compliant with this, does not want injectable therapies and has progressive disease, maybe that kind of patient would be ideal for metabolic and bariatric surgery. And so there are two sets, those who are above a BMI of 30 and those who are below a BMI of 30.
Yeah.
And as I said, as we start coming below a BMI of 30, there has to be a certain duration of absolute attempt with medical treatment and pharmacotherapy. And that is how we follow in our unit. With my wife, you can see here is a diabetologist and physician and our endocrinologist.
Yeah. Sir, Professor Ricardo Lopez also asked a question, because this is interview is just in a light mood and we also take question from our viewers. Have you any predictor to check, so about, can you predict so about the remission of diabetes? So just you have highlighted, yes, when C-peptide must be more than one, you must rule out LADA or any type of autoimmune impact or any other predictor. Can you highlight this? This is a question from Ricardo Lopez.
Yes, thank you, Dr. Ricardo. Very interesting question. The published papers have shown that duration of diabetes, C-peptide more than 3, and the initial BMI were predictors. However, we would add something more, not only published, but some with experience and some with long-term data. So if you look at the SOS study, which published 20 years of results after bariatric surgery, the baseline insulin level was one of the predictor for long-term outcomes. At the same time, if we look at studies from Dr. Yaznik, a renowned endocrinologist from Pune in India, probably the fat percentage and the body composition will have some role, because more the body fat percentage, irrespective of BMI. Why I'm saying this is Indians, Asians are known as thin fat Indians. That means even at a lower BMI, they would have less of lean body mass, less of bone and muscle weight, and more of body fat, which is directly representative of insulin resistance. So we add body composition and body fat percentage and calculation of insulin resistance as one of the predictors. Of course, duration of diabetes, insulin dependence are predictors for long-term response and relapse as well.
Sir, so much thanks. So your answer in detail and definite. Professor Ricardo is live with us. Sir, another thing that you have highlighted about central obesity, that is the most important, especially in Asian and Indian, because there are vegetarian and overall body structure. We can, when we compare with European, so central obesity, and you highlighted 100 to 110 if this is waste. So then, so my question, if patient BMI is 25, and so we see C-peptide is more than 2.5, but central obesity is 110. So have you any experience to do such a cases for metabolic surgery?
That's another very interesting question. Maybe in my life there is only one patient of such BMI. However, we restricted all our studies, clinical trials to BMI about 24.99. That is above a certain grade of obesity. However, there are some published reports on ideal interposition, diverted interposition on patients with BMI below 25. But we, as such, in our unit, with our thought process of endocrinologists, always kept this option of metabolic surgery above a BMI of 25, rather for clinical trials, and above a BMI of 28 for clinical practice. And we still believe that even though there are studies, we still need more of level 1 evidence and long-term studies to generalize and apply this as an indication. So I would definitely feel that the patient would respond to metabolic surgery, but would not generalize and offer this as a standard therapy in any guidelines to our colleagues.
Sir, so much thanks, sir. Another question, so regarding this diabetes type 2, one of the complication is microvascular, and we can see nephropathy, retinopathy, and also coronary. Is necessary to rule out any type of nephropathy or retinopathy in these cases? So because when you deal these patients, there is MDT. Is nephrologist and ophthalmologist are in the part of your team, and all of your patients you rule out nephropathy or no? It depends on the patient condition, selected patient.
Yes. So all these patients do undergo evaluation by an ophthalmologist for the retina. We look for microalbuminuria and generalized tests for renal function, never aggressive unless there is a direct indication. And in addition, there is also a neurological evaluation and a questionnaire for sexual dysfunction. So these four are evaluations, the standard evaluation before any metabolic surgery for diabetes is offered.
Sir, why I ask this question? Because yes, as I know, you are a scientist, not only a surgeon and do surgery and finish. You are following your patients. You have data. So what is your data? So have you seen any improvement in this 4 factor that you highlighted? Have you any data after some years? Yes, no, nephropathy is bad, better than that, and also these improvements.
We definitely see, we have a series of patients who had serum creatinine which was going up above 4. We found that the creatinine stabilized at a lower level, did not normalize, I said stabilized at a lower level. The microalbuminuria definitely improved to some extent. However, it depends on the stage at which the intervention is done. If it is too delayed, when there is end stage damage, then resolution, remission is difficult. However, you arrest the progress of those comorbidities. Very brilliant question. This is a question asked by all diabetologists whenever I present in the congresses, and there are published reports. However, larger studies are needed, well-designed studies are needed for this, but definitely there is evidence that the microangiopathy or microvascular complications improve regarding the macrovascular complications, I believe you need a well-designed study for long-term cardiovascular outcomes. So I will give you some example, some addition. The treatment of type 2 diabetes over years, defined by various organizations of diabetes till 2015 and 2016, were glucocentric. That means they always looked at fasting, postprandial, HbA1c, and control of HbA1c was always important. However, the 16, 17, the trend changed to what is called CVOT trials, long-term cardiovascular outcome trials, and then the outcome became cardioglucocentric. And then the newer pharmacotherapy came in, and the guideline is now more focusing on not only glucose control but cardioglucocentric. And I believe that metabolic surgery for diabetes from day one has been cardioglucocentric and is known to reduce long-term cardiovascular morbidity and mortality as published in some reports. And one of ours, I believe that we are following the ideal guidelines for diabetes treatment, and there is evidence that there is improvement in long-term complications because of micro and macrovascular comorbidities.
Sir, so much thanks. So much thanks. And in this session, in this part, that is a pre-op or patient selection, just last question. So what is your protocol, especially to rule out LADA or autoimmune impact in low BMI? Just because my question is for low BMI, is it routine for all of your patients to rule out autoimmune impact?
Yes, so we do fasting and postprandial sugar, insulin C peptide in everyone. We do the GAD antibodies in all those who have younger or early onset of diabetes, whose BMI is low, where there is history of diabetes in more than one sibling, if at an early age, below the age of 40 or 30, if there are 3 consecutive generations where there is early onset of diabetes, and just to be safe, we add it to all those who get diabetes at an early age, even though the BMI is high. So I definitely believe that one should follow this protocol to rule out LADA in most of your patients.
Sir, so much thanks. So now we are going to talk about some technical points. And really, we are interested to know about your technique, especially for low BMI diabetic patient. If you have any video, any presentation, any PowerPoint, highly welcome, sir. You can share.
1 minute, I'll just open. There are 4 presentations in the center on this stuff which I have opened. So this is one teaching video. So before I share my video, I must say we published a paper in 2009 in SWORD, effect of sleeve gastrectomy in patients with type 2 diabetes and non-morbid BMI, that is lower BMI. So way back in 2007, we started using sleeve gastrectomy to treat these patients, and the results were surprisingly much more than what we thought. And then an international consensus on sleeve gastrectomy, I presented a mechanism. Sleeve gastrectomy, improvement in diabetes without duodenal exclusion, because that time duodenal exclusion was thought to be very, very important. And in today's time, we see that now we are moving to sleeve plus, and there is no duodenal exclusion in every procedure.
Yeah.
So this is how the thought process had changed. That time we started offering Roux-en-Y gastric bypass as metabolic surgery for type 2 diabetes for all our patients, and we still follow the same. And the main reason is we have our own published results, and we have followed our patients for over 10 years. It's a standard procedure, a gold standard, where we almost know everything, including long-term, very, very long-term care, long-term vigilance needed, and even the incidence of relapse or whatever, and the care needed. So we still follow. However, at the same time, I must say there are various procedures which work at a lower BMI on type 2 diabetes because hormonal mechanism is foregut hypothesis, hindgut hypothesis. Any procedure that induces rapid transit of food to terminal ileum will stimulate the L cells of terminal ileum and stimulate GLP-1 and PYY. Any procedure which can exclude duodenum can also add this. Any procedure which can accelerate the transit of small bowel. There is a paper published. That means rapid transit or relative shortening of small bowel will eventually become an anti-diabetic procedure. Any procedure which exclude the curvature of the stomach, maybe by division like OAGB or maybe by something like sleeve gastrectomy would work. So multiple permutation combinations and many procedures would work in a patient who has insulin resistance, who is potential for reversal. I think all these procedures work. Ideal patient, ideal procedure will depend on experience, ethnicity, the dietary type, compliance, intelligence of the patient, and a combination of various of these. I would just show a small teaching video of gastric bypass, which we use as metabolic surgery for type 2 diabetes.
Sir, just during this that you are also, we can show, see your video. So in low BMI, definitely your BP limb is shorter and also you change your BP limb. It differs in different BMI.
Okay. So we don't change our BP limbs ever. Our BP limb is 70 to 90 or 100 centimeters, and the elementary limb is 100 to 150. There are many thoughts on changing the overall length of small bowel, measuring the overall length of small bowel, varying limb lengths, and even people add more to the BP limb, thinking that there is more emission. We know that BP limb is stronger and has more impact, but we follow still a standard Roux-en-Y gastric bypass, and it has always worked in all those, and all the predictive factors remain the same. Probably we need more clinical trials with standard limb lengths and other limb lengths before we can recommend what could be offered for this. Let me just try and share my screen.
Yes, it should be okay.
Where is
Choose entire screen. Yes, thank you, Shah. Yep. You can play the video second.
Can you see the video?
Sir, I can see.
Okay. So I will fast forward and show it. So these are port placements. It becomes little more easy. You can see here in this patient, even though the patient's BMI is low, the liver is still crossing the left side of the abdominal walls, almost grade 2 fatty liver. We use a single instrument for liver retraction. The dissection always starts from angle of His, where we try and ensure that we dissect most of the gastric fundus so that the ghrelin is taken away in the excluded part of the stomach. I will just fast forward here. This is how we dissect the angle of His and make sure that we make it more obtuse. Try and have a look at the left crust and look at the junction between the spleen and the short gastric, and keep a window prepared for the future retrogastric window. You can see here that was the left crust, and now here we are making a window at second level. Sometimes at a very low BMI, we may make it little longer than our earlier pouch. There was a time when we used to make micro pouches, but then we learned long linear pouch, maybe sometimes with a ring, sometimes without a ring. This was taught to us by Professor Malfobi. So this is a retrogastric window, and then we make one horizontal firing, and I'll forward it, and this is a retrogastric window, and maybe maximum two of the vertical firings. Then it is an ideal 20 to 25 cc gastric pouch. This is how the gold finger is used, and this is the last firing. You can see here it is going little close to the angle of His. However, there should be 0.5 to 1 centimeter outside. This is a long linear pouch. Then we always divide the momentum. I'm showing the standard bypass, but my focus is to show that even though the BMI is less in Indian patients, central adiposity is more, you can see a significantly fat-laden omentum even at a BMI of 28, 29. So we divide the omentum, and the technique is like robotic. We take a loop to the stomach and create all the anastomosis in the supracholic compartment. We have been doing this method, which is called simplified gastric bypass, for last 20 years. However, now most of the surgeons have started changing to this technique after robotics came in, because this method is more convenient to follow robotically. You can see here we are trying to measure, and we take about 70 to 90 centimeters. Maybe I'm saying 70 to 90 or 100 is a part of the limb which can lie next to the pouch without any tension. So sometimes it is 60, sometimes it is 70, sometimes it is 90, but longer and more towards 100 is preferred so that we have a strong biliopancreatic limb. This is an assessment that the limb reaches the gastrojejunostomy without any tension. And I must say, in those who have central obesity, the mesentery is fat-laden and thick, and many times remains shorter than those who are thin patients. Now, this is an enterotomy. We prefer to use a linear stapler technique. The most dependent part of the stomach, above or below the abdomen,
Sir, we cannot see your video. I think there is a connection issue. Sir, can you hear me? Yes, just my viewer. So professor is demonstrating the technique of Roux-en-Y gastric bypass. So he will be, just now I think there is some connection issue, but overall no issue. So professor was demonstrating Roux-en-Y gastric bypass, and that is the gold standard technique. And if we see all over the world, still one of the most common gastric bypass, so after a sleeve gastrectomy, is Roux-en-Y gastric bypass. And as a professor mentioned, he's a pioneer of metabolic surgery at the globe since 2007, 2008. So this is the great. So then he was thinking about this when we are doing these changes in this gastrointestinal tract, then we can achieve the target, that is treatment of diabetes type 2. If we see, so when we change this and also change some in GI tract, and so when undigested nutrients will touch L cell of terminal ileum, then so we can see rise of GLP-1 and PYY hormones. And then we, as you know, GLP-1 and also now derivatives of GLP-1 like Saxenda, Victoza, and also Trulicity and Ozempic, that is semaglutide. So definite, these are derivatives from GLP-1. And we can see the result of GLP-1, impact of GLP-1 on beta cell, hypertrophy of beta cell. Personally, I have followed many of my patients, and I see the rise of C-peptide in these patients after surgery. So just imagine before surgery, C-peptide that show us the reservoir of beta cell was 2 or 1.5. After 3 years, when I checked this C-peptide, it was 2.5, rise 1. So we cannot increase the number of beta cell, but we can do, so with this GLP-1, so hypertrophy of beta cell, secretion of beta cell, because overall the theme of this diabetes type 2 is resistance to insulin, and we treat resistance to insulin and we solve this issue. And I think, sir, again, sir, can you hear me? Still there are now some issue of connection, but this is a great opportunity for all of us to hear from someone who is personally a reference and also now following his patients more than 1 decade. And he did thousands of diabetes patients, this metabolic surgery and following. And also if you see in a different journal, his papers that is the dominant role, especially for promoting this metabolic surgery in low BMI. Sir, can you hear me?
Yes, sorry, there was a disconnection,
No
technical error.
issue, sir.
Yes.
Please, sir, over to you,
Can you
sir.
hear me well?
Yeah, we can hear you, sir.
So I added a new point here that those who have reflux disease, hiatal hernia, we add them earlier. Metabolic surgery can be added earlier as an indication for treatment of reflux disease Barrett in those patients.
Please, sir.
Did you get my point?
Yeah.
Patient with a BMI of 28, 27.5, type 2 diabetes, uncontrolled, has reflux disease or hiatal hernia, I would take that patient for metabolic surgery earlier because both the diseases can be treated.
I understand. So this is also a message for our viewers. So if you see, so patient is also has GERD symptoms or hiatal hernia, then no need to wait. So a patient is so low response to diabetes treatment, so we can go ahead because at that time we have 2 or 3 targets for the treatment.
So, any other question? So we can go to the next question.
Definitely, sir. Another question. So regarding this, yes, we know. So this Roux-en-Y gastric bypass, that is one of the most popular surgery at the globe, and also you have highlighted in low BMI, your pouch is longer, little longer, but there is this BP limb and rule limb is standard. So there is no such a difference between this. So my technical question, because as I see, you did gastrotomy at anterior side, and when you will do this gastrojejunostomy, that will be at the anterior of this gastric pouch. Am I correct?
Yes, so what I mentioned there was the most dependent part. So it could be done posterior, it could be done anterior, it could be transecting the stapler line. So if you look at it as a vertical test tube, it should be at the lowest end of the test tube if you look at the gastric pouch as a test tube. However, I prefer not to cross the stapler line when we create a gastrojejunostomy and not have two parallel lines which are close to each other. And that is how in this picture you saw a front anterior gastrotomy.
Sir, my just question, that is a concern, especially many of our youngsters. So when we do this anterior gastrojejunostomy, and when we staple, there is a between two stapler line, we have a space and there is chance of ischemia, and especially burying up that area is much difficult because when we will be posterior to stapler line, and then there is a space between two steps, it is easy to bury and to stitch. But when we staple anterior side, we cannot see, we have no access to that area. But maybe there will be like island, and so ischemia. Are you agree with this?
Yes. I agree, and I would focus more on this if I'm doing a redo or a revision or a second stage bariatric procedure. And if I see such an area, I would use ICG to confirm the blood supply of that. However, here in this, it is an oblique line crossing the vertical staple line and not parallel to it. So that the main intention is to have an oblique or more towards horizontal because it's only 2.5 centimeters. I agree with your point that a narrow area should not be there. And if it is there, one can use an oversewing for that or definitely use an ICG. However, in clinical practice, stomach always has been very kind. Here, if you see, we have not divided a single vessel of the stomach, just made a window close to the stomach and made a pouch. So the supply is intact, submucosal plexus is rich, and even staple lines permit passage of blood almost up to the end. That is why we see staple line. However, one has to be very careful that there is no triangle or they are not very close and parallel to each other. I entirely agree with you and a very important point for all those youngsters.
Yes, sir, regarding this, so if we see, because now we are talking about technical points, so what is the size of your gastrojejunostomy?
So earlier I used to do gastroduodenostomy of the size of the bougie and it did well. However, over years, this was a question asked to me by many people. We made it 2.5 based on various results. See, patients like to eat comfortably and little more, and the newer malabsorptive procedures permit people to eat more. So a pure aggressive restrictive procedure we minimize to 2 to 2.5 centimeters, which is not too big and not too small to convert it into an hourglass stomach. And the results of all these lengths of gastrojejunostomy have been similar, and that is how we base our diameter of gastrojejunostomy only this much.
Sir, are you close all these defects, this Peterson and also JJ defects? It's your routine practice, and how you close, if you close continuous, interrupted, pairs.
Very, very interesting. So this was a loop taken up, and the mesentery is not divided anywhere. Only the small bowel is transected. So the mesenteric defect is a circular small defect because there is no division of mesentery. So a purse string in that area in this is okay. And the Peterson's will be a long vertical one, which can be sutured with continuous or interrupted non-absorbable suture. So the defects are little different in this type of procedures than those where the small bowel mesentery is divided. The main intention in this technique is tension-free anastomosis, ensuring good blood supply to both small bowel and stomach because there is no division of any mesentery anywhere. And if you have tension-free anastomosis, the comfortable lie and blood supply, then you can be touchwood very sure that there is no leak. And fortunately, we have had some leaks in sleep, but no leaks after gastric bypasses so far with this
Excellent.
simplified technique.
Yeah, sure. So, sir, now in this session, so we will talk about your results and data. So now you are following your patients more than 1 decade, especially these diabetic patients, because as you have mentioned, so you have started first sleeve gastrectomy as a treatment of a diabetic patient in low BMI since 2008. So what's my question? Which percentage of your patients so are suffering with diabetes, reoccurrence of diabetes?
Very interesting question. And I hope our physicians don't listen to this. But almost over 50% patients have some grade of relapse at the end of 5 years. The relapse correlates with weight regain. The relapse correlates with duration of diabetes. Relapse correlates with usage of insulin, and relapse correlates with C-peptide levels at baseline. So there is relapse, of course, even though there is relapse, we have a window of remission, a long window of remission, and the legacy effect of this window definitely helps the patient in prevention of long-term complication or having them delayed for some more years and definitely improvement in quality of life. However, this relapse is easier to treat or even to prevent if in today's era if we start pharmacotherapy aggressively in time with the earliest sign of weight regain. And that is how we find that we can prolong the result of any procedure by appropriate use of pharmacotherapy very early in the post-operative period, not in the post-operative period, but over years. As we start seeing slight weight regain or 1 or 2 kilograms, or we find patient's volume is increasing, we start addition of pharmacotherapy at that time itself, follow aggressively with investigation, and keep on accelerating pharmacotherapy. So that is probably a newer norm. Metabolic surgery plus pharmacotherapy will give better results.
Sir, have you differentiate any results between sleeve and Roux-en-Y gastric bypass? So when you started Roux-en-Y gastric bypass, and definite, as you have mentioned, foregut and hindgut, that hypothesis, and when we exclude that duodenum, and then the role of inkeratines that are in duodenum, and when we exclude and all of these hypotheses that you know better than me, So are you think when you have started this Roux-en-Y gastric bypass, result of Roux-en-Y was better than sleeve gastrectomy, especially for a long time?
Absolutely. Absolutely. Even we find that Roux-en-Y gastric bypass is a much stronger procedure than sleeve gastrectomy if you look at overall impact on diabetes. However, there are certain indications for sleep which were not only focused on remission of diabetes. Patients above the age of 75, established coronary heart disease, or maybe some other end stage microvascular complication which could not be reversed, we would not aggressively go on only one glucocentric parameter. And that is what I said earlier. And maybe in this patient, any procedure that can improve diabetes, control diabetes, even with the use of some medications and improve overall quality of life without adding any adverse uh, effect of the procedure, that is where probably sleeve gastrectomy is placed in our clinical practice.
Definite. When the age, so patient is overall a risky patient, then we must go a surgery that is literally easy, maybe less chance of any type of complication. Sir, have you any age limit? You have mentioned 75 years old. If patient is fit for anesthesia and there is no cardiopulmonary contraindication for anesthesia, have you any age limit for metabolic surgery?
Maybe ASS score is the age limit. Maybe that is where, and I'm very happy to share that the oldest patient in India was operated by us 2 months back with uncontrolled diabetes. His age was just above 80. He had completed 80 years of age. Touch wood, he has crossed more than 6 weeks and his diabetes is in remission. Minimal dose, maybe 4 units of insulin required, and I'm waiting for him to be off insulin. However, all other comorbidities like snoring, sleep apnea related to morbid obesity have disappeared. We would reserve this metabolic and bariatric surgery for diabetes for those with morbid obesity and may not be purely for low BMI patients because weight related complications are more in patients with morbid obesity, and that improvement in quality of life is distinctly more than diabetes. If there is someone who has lived up to the age of 79 with type 2 diabetes and has lower BMI, I might as well add smarter and newer pharmacotherapy for him and not offer him metabolic and bariatric surgery.
Sir, so much. Sir, one of the issue that personally I faced in my patients. So this is that they're thinking, they think, so when we will do a surgery and then, okay, we can eat everything and they are happy to start to eat sweets and something like this. Always I talk with them, you are diabetic patient, you will be diabetic patients and you must continue that. So you just think about this. Now, before this, you were taking medication, you were taking insulin, now you are diabetic patient without medicine, but that all of that instruction you must follow. Also maybe some patients, because unfortunately they start and they don't so take care especially about these carbs and like this, and maybe also a cause of relapse of diabetes.
Very well said, very true as well. Once a patient with diabetes, even though diabetes is in long term remission, it is a patient who of diabetes is remission. So I would say still the patient is of diabetes, suffering from diabetes, which is in remission for long time.
Yeah. Sir, another, so because you are doing a gold standard surgery, especially in these patients, that is the Roux-en-Y, and also we all know about complication, side effects, how we deal. But my question about this long pouch, because we are also many times we hear about micro pouch, long pouch, and if we see this marginal ulcer, the main reason in Roux-en-Y that is acid based marginal ulcer. If we compare with OAGB or one anastomosis gastric bypass, due to bile buffering effect, maybe we can see less acid based. Yes, we will see marginal ulcer also in OAGB, but less than Roux-en-Y gastric bypass. What is your experience when your pouch is longer and also in low BMI and maybe little wider? So there is more acid production. So is it increased?
Very, very good point. So even though you see the pouch longer, it is at the second vessel itself. It is not below the second vessel. It is elongated in the video because of the tube and mobilization of the stomach from from behind, from the lesser curvature and towards the hiatus. But I entirely agree. If you have a very long pouch, there will be more marginal ulcer. So I would say the vertical length should be maximum up to the second vessel or between the second and third vessel, and not below that. If it is below that, one should add long-term PPI. But fortunately, and now I realize when you're saying none of our patients of metabolic surgery have come with a symptomatic ulcers, even though we have not scoped them all, but none of them have come with a symptomatic ulcer. And maybe I'll go back and get into the data. Of course, the numbers are not as large as those with morbid obesity. So I will have to look at the results and let you know. But somehow, even though the literature says the incidence of Roux-en-Y gastric bypass, and as a comparison, in my clinical practice, I have not found so many ulcers even after Roux-en-Y bypass. Maybe the earlier pouches were small, or there is something to do with Indian ethnicity or Indian diet or different factors, because we almost completed 20 years, all those patients. But we have definitely seen a few patients of OAGB who have presented to us like those earlier duodenal ulcer perforation, at least 4 or 5 of them, and some of them symptomatic on endoscopy.
Sir, definite, as you know better than me. So one of the reason of marginal ulcer is smokers and also long use of NSAIDs. So definite, you rule out always before going to do this surgery, because when we are selecting our patients, if patient is heavy smoker, patient is a user of NSAIDs, maybe we can prefer sleeve gastrectomy as compared to any type of gastrojejunostomy.
Absolutely. Entirely agree with you.
Yeah. Sir, another, so because I like to ask many questions, but unfortunately due to shortage of time, so we have some limitations. Sir, at this stage, so now you are doing metabolic surgery more than 1 decade. In 2022, Professor Shashank always thinks, so what I do for my patient, for my diabetic patient, are you thinking a new technique for of your low BMI, or no? Still, you will continue Roux-en-Y gastric bypass.
I think we are looking at newer technique. I wouldn't mention it, but I'm looking at newer technique, and I'm more impressed with techniques like transit bipartition, Roux-en-Y transit bipartition, maybe focusing more on lesser malabsorption. But at the same time, we have to find a technique in which there are lesser ulcers also. So the ideal procedure probably is yet to be designed, and maybe ideal procedure will be blunted with newer and newer medications which are derived from interpretations of our metabolic surgery for diabetes.
Yeah.
All these hormonal therapies are giving rise to newer hormones. So I believe sometime there will be a hormonal surgery like how we had for duodenal ulcer. PPIs made the surgery for
Yeah,
duodenal ulcer
I
much
remember.
less.
Yeah.
Similarly, probably I'm looking at some hormonal metabolic surgery in future. We have samples, at least over than 20,000 samples of all those patients of clinical trial saved, where there is a normal population and those who underwent Roux-en-Y bypass, and we have IV glucose tolerance tests and oral glucose tolerance tests with multiple levels. So I just hope and pray that sometime there is some drug and those samples could be used for evaluation of that without using a human being for clinical trial.
Sir, definite. So if so our hope, so maybe the role of stem cell will be in future very dominant, and maybe after some years we will talk. So how much we were doing that aggressive surgeries for such a treatment of diabetes, or other metabolic syndrome, maybe this the role of this stem cell will be more dominant. But now in 2022, when we see this galaxy of different surgeries like sleep plus, so I can say count more than 10 type of surgeries. So maybe we also have access to duodenum, access for a patient suffering with CBD stone. So yes, in Roanwai also we can go from remnant. There is that will be assisted laparoscopic, endoscopic, yes. But again, so direct access to duodenum is easy when we are doing sleep plus, especially in low BMI. And now we can see the results. So maybe also and different types. Now I hear about this jejuno-ileal bypass only. Just they are doing 30 centimeter from this DJ and also some 50-60 centimeter from ileocecal, and their anastomosis only this jejuno-ileal bypass without changing, without a sleeve till without a sleeve gastrectomy in very low till BMI 22, 23, 20, in different countries they are doing, and they are achieving their targets. Also, yes, there are some issues, especially internal hernia, and also they are talking about this. I remember, so one of our colleague, when I asked about these type of technique, and he asked, you are confused. I asked, why I am confused? He asked me, so you have many types of surgeries, but so you have no definite surgery, because he was a internist. So I asked him, how many medicine you have for blood pressure or hypertension? He asked, we have many. So then I asked, sorry, you are also confused. You don't have only one medicine. This is the beauty. So we have different types of metabolic surgeries, and this is the beauty. And we can compare, we can choose one of the best one.
Very, very intelligent comment, and I definitely see that the world and even our unit is slowly moving towards more and more sleepless or small vowel based procedures, even though it's in the initial phase.
Sir, so much thanks. And really, it was one of the best session. And because I was talking with someone who is really pioneer of metabolic surgery at the globe. And sir, so much thanks for your time. And definitely in future, we need your support and your guidance, because we have a lot of our youngsters that are viewers of our GLR and global laparoscopy and robotics, because now we have 11 chapter in different countries of GLR, and we are following training programs and different sessions. If you have any message for our youngsters who are just now going to start metabolic surgery.
Very, very intelligent initiative and very useful initiatives. I must congratulate all of you and wish you all the best for the series in future. For youngsters, I would definitely say one has to be very, very cautious when you start going to lower and lower BMI. The main aim is overall improvement in diabetes, metabolic syndrome, long-term cardiovascular, and all other long-term morbidities and mortalities, and a balance between the advantages and disadvantages is what the surgeon and patient should look at together, not focus only on a glucose-centric approach. That is HbA1c. HbA1c is not going to be the approach in the future. Overall improvement in long term is as good as remission. So the focus should be minimum harm, maximum benefit at the long term, which can happen by right patient, right procedure at the right time, which is probably a dream come true for all patients and metabolic surgeons.
Sir, so much thanks. And really, it is great. It is really great honor. And so much thanks, my viewers. These interview series with your sport. If you have any question, you can ask in your comments and Professor will answer. So we will continue our this series of metabolic surgery in low BMI diabetic patient. And next Tuesday, 10 p.m. Dubai time, we will be with another legendary bariatric surgeon. Again, sir, so much thanks. Really appreciable, and hope see you soon in any international event.
Thank you so much. Thank you for changing and adjusting time
So much
according to
thanks.
India.
So much thanks, sir. Sir, have a nice time, sir.
Thank you.
Thank you.
Good night.